Good afternoon. Oh, let's lower my chair a little bit. Let's get myself in frame. Forget how big my hair is these days. Hi, I'm Jack Chew. My chair's still squeaking. I'm going to swap that over though for next week. I promise. We chew it over 12:30 till 1 o'clock. If you're new round here, we discuss all things relevant to MSK practice, healthcare, and whatever's topical in culture that intersects with those very important things that I'm into. And on Friday's show, it ends up being just extra casual. It's a pretty casual show, but on Fridays it's extra casual. I don't know why. It just feels that way. It's that Friday feeling. And you guys tend to weigh in a little bit more on Fridays, which is good. So I hope this isn't any different. At a moment's notice, I dropped my good friend Rob Beaven, my friend, colleague, esteemed professorial thinker as he is, dropped him a message saying, this is what I'm talking about on today's show. I think it was like 3 minutes before we went on. I said, this is something you'd be interested in. Alistair says that he thinks it's microphone's not working. Okay, Ali, is that any better? You got to let me know. Rob's in the lobby. He says that it's working okay, so hopefully we can just crack on. But anyway, yeah, a moment's notice. I dropped Rob a text, said, this is what I'm talking about, and it's got your name all over it, and he agreed, and he's joining me to do it. So I'm going to bring him in. Rob, are you there?
I'm here, mate. Can you hear me?
Yes, nice one. And yeah, pretty. I mean, we're used to short notice, aren't we? But that was a new record.
I think it was 12:27. You messaged me, so there we are.
Brilliant, yeah. So I wanted to talk about this, and it's not been necessarily planned. It's on my list of things when there's no guest on type list, right? Where at a moment's notice, I'm like, I'd love to talk about that, and so that's where I just thought of you. Is what I wanted to try and do is kind of visit. It's a question and a comment that many people make. Really, I hear it all the time, and I think right. So Ali, can someone clarify whether or not this is a problem with Alistair speakers or my microphone? Because I've tweaked a few dials. Rob can hear me fine.
You're coming through fine as well on my end. But
hi, Michael. Risk. It's a brilliant surname. I'm sorry I'm mispronouncing it. So anyone else that's tuning in, let me know if it's my mic or Ali's speakers. So I wanted to talk about this topic, and because a lot of people ask us that question, and it seems to be, regardless of what sector or discipline you work in, it tends to be a question that people get asked, that people ask us, because they're sort of meaning, if you double down on being the best clinician you can be, does that pay? In that, is it something that is worthwhile on a career sense? Like, is it something that really does eventually pay dividends? People notice it, that sort of thing. Does your manager get it? You know, what if my manager wasn't a good clinician and therefore they think I'm wasting my time and they'd just rather I chomp through some numbers or help the waiting list and didn't really care about the clinical delivery? And then on a business level, often people wonder, well, some of the best paid therapists I know are just the cowboys that me and you are often critical of on our Therapy Business Matters show and elsewhere, and the things that me and you are passionate about on the MSKR side, across both our physiotherapy side and your chiropractic side. We both care deeply about that stuff. So there's almost like a cynicism that people kind of are trying to fight against, to think that they don't want to succumb to that, but they also are a bit nihilistic about, does it even matter? Are we ever going to get valued? So can I throw it to you first on the business side then? As a clinician, a business owner, MDT clinic, and growing, what's your take on that?
It's an interesting question. I mean, I think that arguably it's yes and no. I think that people pay for a degree of certainty, and the more we know about MSK, the less certain we can be. So when someone has, they've had pain for 10 years and someone's saying to them, however unscrupulously, I can get rid of this pain for you, then, they're going to pay whatever that takes, however unscrupulous they are or however kind of non-evidence based they are. That's always going to be a bit of a problem. So I think that on one hand, no, but then on the other hand, yes. And if we look at in the medical world, on average, the highest paid people are generally probably the most qualified. I'm talking very generally here, and that means in terms of consultants, look at consultants' hourly fee compared to someone else's hourly fee. possibly, you can't really say that they're better or worse, but they're generally the kind of the top of their profession, and people will charge more when they get to that level. So I think that yes and no. I don't think price will dictate clinical excellence. So I don't think you are paying necessarily means you get better service in any way. And I think that's true across all all industries really. But it is it's definitely it's a really hard question really. I think there's no right answer.
It's absolutely, it's meant to be. I think that you can argue it both ways. I think one of the things I've really wanted to try and discuss, and why it was one for tuning it over rather than it being like this is a conclusion I've come to, it's definitely one I want to draw the audience in on. So thank you to those that are posting comments, and I really do want you guys involved in this, is that I agree with Rob there. It's just funny because it's 3 minutes notice. It's not as if we planned this, but he's describing that there can be some short-term challenges to it. That, there's some people that have got a lot of courage in their convictions, a bit narcissistic, and therefore, and a misreading or lack of reading of an evidence base that then would allow them to check themselves, means that they then end up selling conviction, which can be attractive in the short term, but then they end up typically letting people down. I know from our second opinion work and the way that we've positioned ourselves in our clinical business, and where I started my origin story going in as a second opinion, even relatively junior in my career, for people to just be honest with them, be honest with their coach, be honest with their directors of their semi-pro club, of which we're about to shell out for a third MRI scan, and instead back their therapist to actually do some rehab. Those sorts of stories make me realize that yes, it can cost you in the short term, but no, it won't cost you long term. And therefore, I'm always encouraging people that this is worthwhile. And I think it's sometimes hard to pick people up for that, though, because they've had a few, sometimes they can take a few punches locally, finding out about said unscrupulous clinicians a few doors down that might be doing something differently and driving around in a better car than them, thinking, well, why is it that I'm aspiring to be rehab centric and trying to engage my patients in a collaborative approach rather than just say passive and gimmick related care.
It's hard to see. It's hard to see that, and right. I think that money is the ultimate motivator, really, across all industries, not just healthcare. And when these people are very driven by money, they're driven by things they don't need but they want to buy. So if you're slightly that way inclined, and I think that is probably the vast majority of people, myself included, are motivated by that. I would be lying if I said I wasn't. That it's very easy to slip into that kind of that side of things, and and I think that new grads especially, they come out, these students don't have money, they work for practices which you and I probably wouldn't work in, but or definitely wouldn't work in, but it's an easy sell, and selling certainty to patients that all they have to do is sign up for this, and it's, on the grand scheme of things, 1,500 quid, yes, it's a lot of money, but it's not £1 million. People will pay that because they don't have to remortgage their house to do it, and so it's not, to a lot of people, to get out of pain, that's not a huge amount of money. However, unnecessary it is.
Have you experienced hitting a fork in the road at various different moments in your business growth where you've kind of felt, well, I know that would be a short-term solution to more capital, but instead you refer back to your values and remember why you're in this, and that the long game is more important. How often does that happen? And when it has happened, how difficult are those decisions for you as a business owner?
I think it happened to me probably more when I wasn't a business owner and when I was in kind of working for someone else. And I think that seeing colleagues and friends, having that money and having that, the lifestyle which potentially that I wanted, and then saying, oh, if I just saw this patient a few more times, or maybe if I did a package of 12 treatments or 24 treatments or 72 treatments, whatever it was, that would be really easy, because I'd only need to see one new patient a week, and then I'd have this huge, this huge amount of money. And I think that my ethics overshadowed that. But I think that I was lucky that I was in a practice that didn't push that. It wasn't that way inclined at all. Whereas I know colleagues who have been in and are in practice like that, where it's very much pushed that way. So I think it was harder for me as what we call an associate working with someone else. Now as a business owner, I think I will think about the reputation of the business and that kind of how I want the business to sit in the community, over the financial reward. And I know that around me or locally there are clinics which have different morals to mine, and I see a lot of patients because of that. So then I will also probably almost go too far in the other direction, to try and disassociate myself with that, which is also a problem because arguably, and we've spoken about this before on our podcast, the therapy business, about how you can go too far in the direction, and people do want guidance and do want care. And if you're dismissing everyone and not following people up correctly, then that's arguably difficult too. So there is a balancing act, but it's as Michael has said, be certain in uncertainty. And it's that's an interesting comment.
Absolutely, yeah, and I think that is something that I would. I love that the conversation's gone there, in that there is uncertainty in the clinical decision making in many ways. The various different causally relevant information that you might draw from people in a thorough assessment these days. It means that then there is more contributing factors. It's vaguer, it's more complex, it's more uncertain. Therefore, there's a way in which you can then communicate that. An expert clinician doesn't then unload all of that uncertainty, untrammeled, unfiltered back to the patient. But it also admits to having a working hypothesis and a collaborative approach to trying things and scaling someone's functional abilities within the constraints of their specific goals, rather than being dictatorial as to this is the style of care we're going to deliver in this manner to you, at you, on you. And it's one of the things that's interesting, and why the former words that I chose for the title of this, does it pay, is because you sometimes say, does honesty pay off? I'm not necessarily just associating the money to it, but we're right to talk about money because that is one of the ways in which value is ascribed and associated, and a motivating factor for people to achieve various different things and goals in their own lives. And so I'm it's a funny one because as an entrepreneur and as a business owner, I have to pay attention, of course, to money. It motivates me in some ways, but I'm not particularly material. It won't surprise anyone as they look at me with my 90s boy band haircut that cost me £8 a quarter to get tidied up. I'm someone that famously untrendy in every which way. It means that kind of helps in some ways. But the reason I bring that up is because even though I'm not that guy, it's certainly naive and I think a bit foolish for people to imply that money doesn't matter at all to them or doesn't motivate them at all, in part because there is something that even on a social value level, for a sense of fairness, if you are across a desk from someone that is being paid more for the same work, there's an inherent social injustice to that we kind of know that if we're living in a society of which ascribes this value, and there is a base rate and a minimum wage and the likes of that, then we need to recognize and be valued appropriately, regardless of the material things of which you can buy with it. And so that's why I talk about, does it pay? Meaning, is it worthwhile in every discipline and every industry? And what you've just described there, Rob, makes a lot of sense, where you've got to see that bigger picture. And reputation, that can be something that is incredibly challenging and costly to build up, but it can plummet off a cliff. And that's clearly something that you've got in mind when making those decisions. Do you find that motivating your staff in the same direction? Because you've mentioned then as an associate, you felt slightly differently. How about your associates and your staff? Do they sometimes wonder, why does it matter if I'm particularly clinically excellent at treating the rotator cuff? If my patients like it for now, then why does it matter?
I think that comes down to partially how you've chosen your staff. And I think, obviously talking very well about my staff, I've, selected people who are very well in line with my beliefs and our clinic's philosophy. Right. So someone who came in who had a very different mentality to that wouldn't work. So it wouldn't fit in. It wouldn't fit in with our clinic, our clinic processes. So I think that comes down to how well you've set that up and set up that ethos in your practice, with everything from your admin team to your current patients to your other staff members. And if you had someone who's coming in saying, "Oh, I'm going to see you for 10 minutes. I'm going to see you 24 times," and that patient's been seeing someone else, they're going to think, "Well, hang on a minute, this is something different," or why is this different? Or the reception team are going to start questioning it, thinking, "Oh, you want to book how many appointments?" And it wouldn't. So
the culture, contrast with the culture of the.
Yeah, so it contrasts with the culture. So I think that comes down to how the culture which you have in your clinic, and that is is a vital part of any business, really, not just healthcare. That kind of fitting into the pre-existing culture. But no, I think that having that discussion with staff around why we do stuff is important. I haven't needed to have that. Maybe I should have done, but I haven't needed to have that because, I trust my staff's judgment. I'd refer my grandparents to see all of them because I trust their judgment and what they do. So I think that ethos is the biggest part of it when it comes to it, and that keeps people in line and stops them. I say stops them going off on a tangent because it's not for me to. It is for me to control it, but it's their clinical decision at the end of the time. I'm not going to sit down there with people monthly and say, "Oh, you've seen this patient 6 times when I probably would have seen them 3 times over 6 weeks or whatever it was." I'm not. That's what Bupa do. That's not my job.
That'd be a weird micromanagement, wouldn't it? And clearly, someone that's kind of got an insecurity over why they needed to transmit not just a clinical model of care delivery, but then sort of the clinical operations side to it, which they're going to have better insight than you would, whether you're reading records or looking at numbers and stuff. Is that you've got to have hoped you've hired the right people to then be able to back their clinical decision, and that they have better insight than you and always will do. You hear, though, don't you, of that micromanagement happening, whereby it's not just someone saying, we like to have this clinical ethos here. There's sometimes people being fairly heavy-handed in the fact that they want to imply that the data needs to be such a way for the clinical product to be consistent. And that seems to... I've never heard of that being done without it undermining clinical judgment, and that there is someone that's being a business leader or even outside of business, just being a manager of services, that then is implying that my way or the highway, or I would do that better. It's not I'd do it differently or asking questions. It's an inference that there's a higher quality of either more or less care.
Yeah, and that's not saying that measuring KPIs and stuff are not important, because it does give things, but it's that micromanagement, week to week, month to month, singular patients, as opposed to things across the board. If you're having 50% of your patients not turn up to their follow-up, then there's obviously something going on there, that's slightly different. So keeping an eye across those metrics is important, but it's that overarching view as opposed to, helicopter management or helicopter, like helicopter parenting, isn't it?
Sure.
Micromanaging every single decision.
I think and we do this on our podcast, which we need to record a fresh one. We text this morning, didn't we, about that? Let's get that together. But you've got to give the people what they want, Rob. Of course we do. Yeah. But I wanted to sort of mention on that show, we often talk about it's not that dissimilar to clinical practice in that, and we use like an analogy. And in this instance, it feels fairly straightforward in that you can understand why people would want to constrain and restrict the way in which people practice, because it's informed by the evidence, right? So you get an RCT that comes through that kind of rocks our world, that tells us something about shoulder pain. And the application of that, any contemporary clinician that's thoughtful about this will integrate that new knowledge into their reasoning framework, right? It might expose certain corners of it might surprise us, but you'll integrate it into your reasoning. Whereas others would want it to be almost like a battering ram, and that should then be the starting point. It should be the new foundations for everyone else's thinking and stuff. And it's a bit of a clumsy sort of sense of empiricism. On the business level, if that's how you're using KPIs as a battering ram, rather than, isn't this an interesting piece of information to start to a jigsaw piece within the puzzle rather than the puzzle itself? That's how I see these things, because it's certainly not, be clumsy if I were to come across as if I was being dismissive of that data being brought to bear in people's evaluations, either of themselves or of a service and stuff. But it's just that then, if you don't drive towards the clinical excellence within those interactions, then what is it for? What are we doing? We're meant to be helping people with their sore bits, right? What on earth are we doing if we're leading with the data as a consequence rather than the care delivery? And I think that's something, obviously, we have a lot of kinship for. Do you think that where would you say we are? Are we in the majority or the minority on that, on our instincts in that?
I think I think we are moving into the majority in that. I think that if you're taking professions out of it, I think that across all, if we call MSK professionals, I think we're in the majority with that. And I think that is something then which will also come with experience, and maybe that is what that clinical excellence comes along with, is experience, and that might be something that we're not accounting for. And if you're looking at someone who's been treating shoulders for 30 years, and people jump to mind, but if someone's been treating shoulders for 20-30 years, they're going to take that. They've had 30 years of that clinical experience, and all of the brand new papers that have just come to the forefront over 30 years, they'll be relying on that whole body of evidence and experience as well, which we undermine. Whereas if you and I graduate tomorrow and start seeing shoulders, we can be aware of that entire body of evidence, but we don't have that experience. And maybe that, that experience is what, counts largely towards clinical excellence, is experience over that, because anybody can, I say anyone, most people can interpret an RCT and implement that into a program, into management with a patient, but that expertise which you have from 20 years will play hugely in that. And maybe maybe that's what counts as clinical excellence, or counts a big part towards
it should be, shouldn't it? Especially that a reflective practitioner, what they're doing in that time matters, doesn't it? You can have people. I've got good friends who are brilliant clinicians now, but they'll talk about a window of their career in which they feel that they weren't getting the reflecting appropriately, they weren't supported, that sort of stuff. I think it's an interesting one. We've got some great comments coming in, so I want to make sure I bring you guys in as well. Another one, cracking one from Michael here. Great clinicians, I believe, communicate really well and connect with people as well as understand research. If you connect well with humans, you'll be busier and get paid more on a commission model. This idea of, and he's mentioned there at the end, there's a few different ways in which that pays off, doesn't it? And that speaks to what you were describing, is that it's not even that long a game, but at least in the medium term, it comes back around, doesn't it?
Oh, for sure. Yeah. And that relies on the business management, referrals, and all those things that come with it. If you're known as the person that isn't going to rip someone off, then that's always a good business model for you, isn't it?
Yeah, when your referrers start sending their family or turning up themselves with injuries, then you know that there's something there, that they're trusting you on a slightly deeper level than it just being convenient. Because sometimes, you can't take too much in referrals, because sometimes you've made it convenient for them, you're local, people fancy it. Whereas then when you start to get that deeper level of referral, then it makes a big difference, doesn't it? Angie's made up a great point here. I'd love you to unpack for us, actually, Rob. Undertreating may be more unethical if the person re-injures. Such a balance. It's such a great point, isn't it? So, 100%. Just take that a bit further, because it reminds me a bit. We did have that in our last Therapy Business Matters podcast. But just what's Angie meaning there? What examples could you give us?
So I think we speak about ACL or hamstring. I can't remember. It was something. It was an acute, grade 2 hamstring. It was an ACL, something like that. And what I think we were saying about, if we have a football player and he's saying, I want to go back to football, I want to go back to running, and it's very hard to let a patient, to give bad news to a patient and saying to someone, this is going to be 3 to 6 months before you are doing X, whatever that task may be. But then it's very easy to then, do you think I could do this? Do you think how about a quick game this weekend, or could I give it a go? And I've done it, and I've been there, and I've said, maybe try it, because you want to please that patient, and it's really difficult not to. And I think that kind of undertreatment, you should be fine, go see how it goes, and not following up and not giving those patients the correct expectations, that then leads to re-injury. If you're sending someone 4 weeks after an ACL tear to go and play a football match because they've asked you if it's okay, then that's probably not going to end well, or not likely going to end well for that patient. So there is that kind of expectation. And, if you're not telling someone that this is going to be, 6 months plus of recovery, whatever that is, that doesn't mean you're seeing them every day. But it just means that you're checking in, you're following, you're emailing, you're managing their expectations and their recovery. Then that is good practice. Yeah,
it's a really good point. And Angie, I think that sometimes we talk, and I've made this mistake, hopefully less so these days, but I talk about the unethical upsell more than I do the unethical downsell, and the fact that sometimes people are underserved is clumsy. And also, it's not just on an interventional level or one therapist. It's like the service spec of some businesses in our space sometimes leave people hanging. We see a lot of second opinions whereby people aren't happy with the care they've had before, but we also see some people that were really happy with it, but it left them at 70%. And they want to get back to their PBs if it's an athlete, or they want to actually get back to being able to tolerate overtime in a warehouse, and their back sort of flares up because they've not quite got the capacity, for want of a better term, or they're just not 100% yet. They've kind of been discharged a bit soon, or they've not, those services don't have the provisions or resources or staff skill set to see them all the way there. That's something that that's not over. That's under treatment, really, for that person's specific goals, or they've not been given the appropriate guidance to get themselves all the way to 100%. Of course, I'm discharging people at 70% plenty of times, if appropriate, for the fact that the trajectory means that they're likely to be there in a matter of weeks, or that's their choice, especially those that are traveling away.
Dependent.
Yeah, because
well, some patients are going to expand, and some people, you can send people away after, they can be in a lot of pain, but they know they're capable of managing it, and they can be fine with an email in a week or a phone call in a week. Whereas some people are going to need a bit more hand holding, but that is the part of our job, is recognizing who those people are.
Absolutely. Now, one thing I wanted to make sure I throw in there as well, because again, for those that are just tuning in, really lucky that Rob was able to join me at a moment's notice, and we've been able to therefore really double down on some of the financial perspective on private practice, but just a nod to the fact that I was going to then go across. If I'd have been solo, I'd have been probably doing more of a broad span across the different sectors. And my experiences, particularly working in the NHS, which I did for best part of, if not 10 years, including up to advanced practice, there were lots of this conversation happening, not necessarily just on financial reward, but is it worthwhile as a careerist, even if you were to stay within the public sector? Is there just a conveyor belt where time served means that even if you're not so good, you're still going to be able to go up the pay grades? I think that there's some legacy of that, and you see some of those relics. But fundamentally, I think these days there's a lot of pressure on those thresholds. Now, within bands, it's very rare that you hear of people not getting a natural arbitrary pay rise within pay bands on that grade. But now that it comes to actual competition for those positions, then typically I think that there's something to be said for clinical excellence there, especially with regards to the overlying governance that Health Education England are bringing into advanced practice. I think that's going to help, because they're no longer arbitrary standards. It's no longer you're good at sitting an interview in front of your mates and they then give you a job that then just rubber stamps you at the same skill set for another pay band. I think those things are becoming less arbitrary, which is good. Jim's made a point about the fact that currently there's a monetary benefit to going into diagnostics rather than rehab. When it comes to clinical excellence, you can be clinically excellent of either of those roles. Now, we are fairly vocal in saying that we want to make sure that rehab doesn't get left behind. But generally speaking, we definitely don't want people, you'd sooner someone being brilliant at diagnostic triage than not being. He's still aspiring to be brilliant at whatever it is they might be doing and whatever role it is. So
you pay for responsibility, I guess. That's what you get paid for responsibility, and maybe that goes back to that the surgeon type thing. They have the highest level of responsibility because they could far easier kill someone on the table, and that's what they get paid the big bucks for, really. Whereas and that diagnostic side of things, that's what you're paying for, is that at the end of the day, it's to be safe, and it's to rule out serious, sinister problems. That's what is the most highest risk part of our job, and I guess the higher up the chain kind of diagnostic type spectrum.
And also interventionally as well. One of the things that I remember, it felt I wasn't comfortable with it at the time, but realizing just how me being someone that injected medicines into people occasionally meant that then brought with it, in certain jobs that I was being invited to interview for, it was like a literal crisp line in salary, which felt weird. And then I came to realize, although it was clumsy how it was being worded compared to the position that I held, you understand as to why the responsibility for me injecting substances and medicines into people's bodies, into the right locations and the like, is not just a skill set. It's also that responsibility that you're describing, right? It's that thoughtfulness and that more professional governance that kind of came from that intervention. And so there's something to be said for that risk reward basis that people need to take seriously, and also understanding those economic factors in across the sector as to what motivates those sorts of things, and not being clumsy or playing politics with it. So a fascinating one. I've got a question here from Angie. We're out of time, and I looked at this and I thought, I can't think of a better title for another show. That's the thing on Chewing It Over, is we don't need to visit every corner of this topic in a wanna. So Angie, if you're still listening, or even if you fancied maybe getting into this with me, then that'd be perfect, because I think that innovation meets legacy evidence conversation on clinical excellence, I think, is a fascinating one, and one that we could visit in a few different ways. So I don't want to necessarily try and squeeze that in here, but thank you so much for your time, especially on short notice, Rob. It's been brilliant.
Happy to, mate.
Flies by. Anything else you want to add or leave with?
No, I think that was good actually. I liked that question actually, so I'm just looking forward to doing that one. So hopefully,
I might give you more than
Monday.
three. I might give you more than 3 minutes notice.
Yeah.
We've got some covered shows from Jim and Flick next week. As I'm still local, but technically trying to down some tools and take fewer meetings. So maybe you'll have Rob lead on that one perhaps as we crack on. But also it looks like Angie's happy to chew that over. So maybe that'd be cool. Can I leave that with you, Rob? You and Angie.
Yeah, no worries.
Doing it over sometime soon. That'd be brilliant. Obviously, I'd be happy to as well, Angie. But I'm not on the shows next week. So, thank you so much for the participation. Always love a Friday show. It just gets a bit more lively. I don't know what it is. Everyone's got the Friday feeling, but really enjoyed it, and we'll all speak to you all soon. All right, take care. Thanks, Rob.
All the best. Thanks for tuning in.